cover, and we've only got an hour. So I'm going to let Jose, kind of go through the agenda, and then we'll jump right in.
All right. Good afternoon and good morning to you if you are on the West Coast. We're planning to discuss a couple of issues that we would like to get some big feedback from you guys, specifically on some of the most important issues right now in public housing primary care. We would like to recap a session that happened at the last NAC conference in regards to the ideal health center in 2025. And just going back and review the two HUD's initiatives, smoking cessation and envision centers. And there is a topic that is, we would like to get some feedback from you, specifically in regards to the transformation of public housing and where public housing is going. And then just get some information about your attendance to the Public Housing Task Force at the PNI and CHI conferences. So I believe that we're going to start with the emerging issues. We are working on the work plan for next program year. And as you may know, HRSA has diabetes as one of the major initiatives. We've been working on diabetes for the last 2 years. We have an advisory group, and we've been working with some clinicians and nurses and director of quality improvement and gathering some best practices. We've been in contact with the American Diabetes Association, and we've been working with them and providing feedback to the diabetes primary training and the 2019 standards of care guidelines. We've been working with the other NCAs, the other 19 NCAs, trying to establish new training and technical assistant activities. And we've been working with NAC and the diabetes task force that they have in place, and specifically they've been working on a toolkit. So that's the major activities on diabetes. At the same time, we've been working on cervical cancer and social determinants of health. But we would like to hear from you specifically if there are any particular issues that you believe are important that we shouldn't be including as part of the TTA activities that we're planning to develop. And if there is anything that you are working on right now that probably you may need some assistance. So those are the activities and the emerging issues that we will be working on. And if there is anything at the national, state, or local level that you believe that we should be including, let us know, and so we can include some of the activities. So we need feedback, right? And if there is anything that you believe is important right now, I mean, this is a very good opportunity to let us know.
This is Zara from La Maestra. I know, Jose, we've been in touch with you and worked on the social determinants of health, and I've spoken about it at length on these advisory call meetings. It's a model we've been working on for years, and we've made a lot of progress in terms of the case coordination, the software development piece, and basically being able to cull the data in a way that indicates and demonstrates that the social determinants of health integrated in a primary care model really is impactful and brings value to the patient. So we're excited because, knowing that a model works is one thing, proving it empirically is a different one. So we're really down the road on that, and I'll be happy to share that with you. The other thing that's super important for our populations right now is that connection between, the diabetes clinic. We also have one. I know Sonia Tucker has been involved with that program, I believe, with you, Jose.
Yep.
And the connection then to the liver clinic and the fatty liver scan and the follow-up and the protocol and the best practices and how does that integrate and what an impact on our populations that's going to have.
Okay.
So we really think that is the logical place to expand that diabetes clinic to include, liver, because that's what's going to happen. And then, of course, where in terms of here, our activities, I don't know how they're going to parallel with your priorities, but, we have a lot we're providing services down at the shelters for the asylum seekers, the caravans, right, that are coming across that actually do make it across in immigration. ICE parks them at, dumps them off at different shelters, or they find their way to these shelters. We're there in the evenings and weekends. So if there's anything that, in terms of, chronic disease or disease management or, triage right away for different, issues, we're seeing a lot of the human trafficking, a lot of abuse cases in kids and adults, a lot of the psychosocial issues of being, having to stay in a small space with lots of people, in one area for prolonged periods of time, and your perpetrator's right in there.
Mm-hmm.
And the whole fact of not being able really to talk because you're worried that that's going to mess up your case because somebody sponsored you and you're just waiting to go from point A to point B. So those are some of the issues aside from, the chicken pox, the TB, all of that stuff, And let's see, the other one, of course, the homelessness, all the issues with homeless, hepatitis A, outreach. Where is it that we're going to be referring all of the, for all of the contextual needs? There's not enough sites to refer, just housing, for example. What's going to happen? Everybody's, the state and the feds and everybody's talking about all these mandates they're going to have, like to the hospitals. Like they can't just discharge people without knowing where they're actually going to go and make an effort so they're not throwing them back out on the street. Well, that's cool, but where is it that they're going to refer them? There are not enough housing structures to take care of even a bit of this problem.
Mm-hmm.
So I think that's where more of the housing is going to come in terms of health and housing. And, and like we've already started working years ago with the correctional facilities. So for the reentry program, then that comes into it, and the opioid treatment programs that we have, that is also part of it, and the transitional housing, which we're going to do more of.
Mm-hmm.
But, from that programmatic, integrated perspective, not these silo, let's just go after one thing and not have it connected to anything else, doesn't work.
Yeah.
Yeah. And Sarah, thank you so much for this. All these topics, and this is very helpful. This coming Friday, we are planning to have a conversation with the Supported Housing NCA and the National Council specifically to see how the three NCAs can work together. And I believe that the homeless topic that you mentioned and the outreach and the referrals and all that stuff is very important, so we can touch base with them and come up with activities.
Yep.
Now, Sarah, I do have a question for you in regards to the case coordination topic that you first mentioned, and specifically, what are the needs, Sarah? Do you think that is a toolkit, a webinar? What do you think is the best training activity or vehicle to discuss this topic?
Okay, so the advanced case management, which was what we call it, around the social determinants, correct?
Mm-hmm.
Capturing that data. Is that what we're talking about?
Yep.
Okay. So the learning curve is like, okay, so we're going to make sure we have all of these resources, make sure these are the pathways that are still established. Let's kind of update those pathways so we can do this social prescribing, which is what it's called abroad. And to do that, you need to have enough resources to do the social prescribing, because you can't just sit there, capture that information from the patient, and then tell them, okay, great, well, now we're going to refer you to the housing over here because you told me you're living in the street with your kids or your car, and then they go there and there's not enough housing.
Mm-hmm.
Yeah.
That is irresponsible and horrible. Okay. So you get to that realization, and then you start saying, okay, well, there's not enough resources out there. That's why we need to develop this resource within our organization.
Mm-hmm.
Some organizations might do that. We have, precisely for that reason. Now, capturing the data. Unless you can prove that things work and keep track of people so they don't fall through the cap, outside the referral system for the clinic, the medical services, we have this other piece, which is how are you going to case manage your patients, your clients, right? Because maybe they came in through a different door, not medical yet.
Yep.
And how do you know that they got to all of these other places that you referred them to? And, some of them are, like it's really serious that, that somebody stay behind these cases. And then document and track and also how did that work? And did you have access? And if not, how can we help you access that service and then get the result of what happened? All of that needs to be captured somewhere. And if that client isn't a patient yet at your clinic, you cannot put them in the electronic health record, right?
Right.
So you get back to that dilemma.
So what do you do, Zara? What are you doing to collect the data?
Okay, we went through 3 different programs that we developed part of and then added. We have 2 different things that we use. One is like based on a Salesforce launch something platform.
Yep.
And that captures, and it's been tailored to fit all of our non-medical services.
Mm-hmm.
So somebody enters and provides all their information. They don't have to go through the same thing when they get transferred to another one of the programs.
Yeah. Now, Zara, once they become a patient, does the EHR then accommodate tracking as well into the other social services?
Only because our IT team messed with it to get it to do that.
I got you.
Okay.
Because otherwise, if regular health centers have to go back to their EHR vendor and say, you know what, we also want to capture these fields. Okay, you're going to pay some good money.
Yep.
Yeah.
So all of these things are really it's really paved the way to being able to capture the data.
Yep.
And manage those patients navigating these really super important services.
Yep.
That will affect their health outcomes.
Yeah. Okay. Thank you, Zara. This is very helpful. For those who just joined the call, we are discussing some current and emerging issues in public housing primary care. If there is anything that you believe we should include in the activities or anything that you would like to hear from the National Center for Health and Public Housing, let us know. And I believe that this is a very good opportunity to let us know if there is any issue at the national, state, or local level that you would like to discuss.
So, Alan or Kim, do you have anything you'd like to raise up or comments on?
Yeah. Go ahead, Kim. I have one, but you go ahead.
No, I was just going to say, no, I don't have anything at this time.
Okay.
Well, so I'm curious. Bob and Dr. Leon. Are you all looking at, and I'll say this term, it's ACE, ACE, and I'm not talking about Advocacy Centers of Excellence. It's called Adverse Childhood Experiences.
Yeah.
Yep.
Are you all looking at integrating that into some of the work that you're doing?
That is correct, Alan, and thank you so much for that. We've been working with the National Council on Behavioral Health, and we did a webinar on ACE, I believe last year, but that's one of the issues that we've been discussing. In fact, Bob met with someone at the National Council, and we are planning to include ACE as one of the activities. That's really good.
Yeah,
Thank you.
Yeah, absolutely, Alan. Is there anything specific that you'd like to see there relative to adverse childhood experiences and adverse life experiences?
I'm probably not the right person to ask. I've been to the ACE presentations multiple times now, but there's just so much to get your arms around. However, I mean, a whole lot of those are essentially social determinants of health. Plus, it's targeting children.
Right.
So we're at the the beginning phases. We've started implementing ACE at our pediatrics, obviously at the pediatric side, but we have a whole new division that we've added on, much larger division for pediatrics, and just like in the last few weeks, flipped the switch on doing the essentially the ACE evaluation for each child that comes in. So, but if you're doing it already, I think if you weren't doing it, I would strongly suggest that you would. But if you are doing it, then bravo to you all. Carry on.
Well, you know what though, Alan? I mean, we're glad you raised it, and glad Zara raised all the points she did, because the problem is that there are so many issues that are really important, and getting feedback is really helpful in prioritizing getting attention. Because, for example, we talked about diabetes earlier, and diabetes is the HRSA priority, period. As we work with them on this National Resource Center with the other cooperative agreements, they have told us diabetes is their priority, period. Now, there are other obviously super important issues that we want to raise up, and so having this discussion really helps us do that. And in fact, we're going to be meeting with with Jim and Tanya and the HRSA folks at our kind of annual, sit down with them, probably next month, if not the month after. And we will definitely be addressing kind of some of the points that you're raising. And we'll definitely talk about, ACE and trauma-informed care and those issues as well. And I'm particularly interested too, there's an issue that's down the bottom. We'll get into a little more about the transformation of public housing. But, and Zara, I guess I'm interested from your standpoint, because you talked about a lot of issues in terms of resources and, for example, finding housing for people or some kind of transitional housing. And in San Diego, my understanding from our previous conversations and some of the stuff we've looked at, San Diego is different than a lot of other cities because they really don't have much, if any, traditional low-income public housing, but they have a lot of project-based vouchers and project-based rental assistance.
Correct.
And coordinate services that way. So in terms of the point you made about the difficulty of finding housing, how are you working that with the housing authority versus how you might be working it through either a supportive housing group or a shelter or a transitional housing organization?
Well, see, that's the problem, is that there are not enough organizations that are providing shelters. Okay, number one. Number two, and working with clients that require shelters for the last 30 years, you get a good idea of who is there and where you can put people. It's just there's just not enough. Just look at the homeless issues out here because of the weather and all kinds of stuff. What kind of housing is going to be augmented to accommodate that population, and what kind of combination of housing, shelter, like maybe more care, more treatment, and then what? And is it going to be like sober living? Is it going to be long-term kind of care? Are there going to be, supportive services like mental health there?
Mm-hmm.
Addictions. I mean, all of that has to be considered. There are very few, and there are temporary solutions.
Yep.
And some of them are being experimented with, like, the whole idea of letting people bring their drugs and their drug, abuse into the living situation, and with the hope that eventually you can work on them because at least they're inside out of the element.
Yeah.
Well, talking to people that are real advocates for NA and AA goes against all those principles. So, they don't want that. That's been a huge debate, controversy over the last how many years. But still, the funds haven't really come through to do more housing. We have seen California with some of the bonds now that they just passed for the tax credits to go into these homeless housing specifically.
Mm-hmm.
The issue with that is that they'll pick like downtown, they'll take an old hotel, they'll convert it, even though the proposal will require supportive housing, they'll say, okay, well, let's pick the closest clinic, we'll put them down here, let's pick, whatever the job training thing, let's put them down here, but it's not integrated. So they just end up providing housing, and we as a community have recognized that now, that's not what ends up happening. It ends up being like, a Band-Aid solution that's like going nowhere. So I think that in terms of models, I think that our state is looking for models in county that really do incorporate and demonstrate that they work these integrative, supportive services on site in the housing, so it's not just, turning into another low income, rent by the day kind of deal.
Mm-hmm.
This is just horrible. So those are some of the like light bulbs that have gone on, and we'll start seeing more housing, hopefully, being developed that is low income and has these services that actually resembles more like a program.
Yep.
Rather than, just going and renting a space. Because these vulnerable populations really require these other services because they are the social determinants.
Yep.
And that's what it is.
But Zara,
that's kind of how I see that working.
But Zara, just to clarify, when we talk about kind of more service and housing integrated programs, are you talking about transitional stuff where somebody's going to move on and get better, say they have an addiction issue, or are you talking about people who maybe have a disability or are elderly and are going to need some kind of permanent long-term assistance?
Yeah, I mean, all of that has to be addressed. And the whole debate before, well, should we really call it transitional? And then for a while, people didn't like that term because it kind of implied that it was very short term and, these kinds of arrangements that are like, 1 month long. No, it has to be, now they're back, transitional is okay, maybe leading into sober living, which is more permanent, long term. And yes, there's going to be seniors, there's going to be veterans, there's going to be disabled people, because that's what our society is like.
Yep.
So hopefully that housing isn't going to have, all of the seniors segregated over here, okay, all the people with disabilities over there. That kind of stuff does not work.
Yep. Gotcha.
Thank you, Zara. Thank you so much. I understand that we have people who joined the call. I know that we have Kim and Zara and Alan and Saki on the line. Who else has joined the call?
Kent Terrell from Macoupin County Health Department in Illinois.
Thank you so much for being with us today.
Excellent.
Yeah, you're welcome.
All right. All right. So do you want to move on to?
Yeah.
target space?
I'm not sure if you would like to talk about the transformation of
Okay.
housing. We want to
Okay,
go
we're
back.
just going a little bit out of order here, and we're going to jump into, because we kind of touched on some of the issues in the last discussion, and that's transformation of public housing. I mean, everybody knows that traditional low-income public housing has been basically changing over the last, especially over the last 20 years. And of course, the move has been to go from traditional, centralized public housing developments with just public housing residents, where there's the public housing agency owns the units, and they get money from HUD for rental assistance, more to a situation where there's kind of mixed use and scattered sites, and where they're using a lot of private housing, and basically what the housing authority is providing is a process, and from HUD funding for housing choice vouchers, and sometimes project-based rental assistance or project-based vouchers. And there have been conversions through moving to work and through the rental assistance demonstration program. Especially RAD over the last 5 years, there's been a great movement, and I guess the big benefit from RAD, as people see it, is that basically they're leveraging the monies that in the long-term guarantee of federally guaranteed housing assistance vouchers payments through housing choice vouchers, and they're using that guarantee to get financing to get people to buy or renovate properties, or in some cases build new properties. Now, some of the downside of that is in some cases there's a loss of services which inadvertently happens, and a loss of community in some cases, depending on where they are. But as this is happening, we're kind of interested in feedback on what's happening in kind of your locale. And I think we got a sense of what's going on in San Diego, Zara. But I guess, for Alan or Kent or Kim, I'd really be interested in getting some feedback on what you guys are seeing.
Well, as it relates to public housing, we're really not seeing, if you're talking about like conversion from the traditional public housing to a hybrid, or even just fully moving away from the traditional,
Yep.
We're not really seeing it. We're not seeing it at all. It's just basically it's business as usual for us. So
Okay.
which is kind of nice, frankly. I'm sorry everybody else is going through all the drama, but we're fairly stable at this juncture.
Now, Alan, how are they financing, just maintaining the properties and renovating the properties?
Yeah. Well, they. I mean, I don't know what to tell you. There's it's a good community.
Okay.
And I think that they get a certain amount of assistance from the state, or the city and the county governments to be able to subsidize their operations, and then there's the rent payments coming in on their own. But they seem to be doing a pretty good job. Now, we're not talking about Taj Mahals here. I mean, these
Right.
These are older units, and
Sure.
older but well maintained.
Okay.
Is what I would say. So it doesn't look like any of them are. I actually just drove through one of the complexes 2 or 3 days ago, and I was kind of marveling at how clean that they're keeping it, and sort of thinking about it in terms of even though it doesn't have a direct impact with the federal shutdown, kind of wondering how different places are being impacted by this. Literally drove over to see our clinic inside the public housing and drove through that particular complex, and it looks pretty good. It's just as good as it always has been.
Mm-hmm. Mm-hmm. Okay.
Sorry, I wish I could give you some stories of drama.
No. But it's actually helpful to know that some people are kind of status quo. So that's good to know. How about you, Kent?
Well, actually, we've had a transformation, but I think most of it is HUD funded.
Okay.
If there is private funding, I'm not aware of it. We've had extremely old scattered old traditional public housing buildings with either one level or two level, and they got to the point where they couldn't be maintained. And what we're seeing now in a lot of our communities, we've got a pretty aggressive housing authority in our base county, which is Macoupin County, but then we actually serve the surrounding counties as well. And they're going to these really nice duplexes, and I know it's still but you do pay. So they're going rent based on income.
Yep.
And actually, we've had a big conversion over for elderly, and they do take Medicaid as well. And that includes assisted living and supported living for elderly. So we've got a lot of upgrade. Now, there's a lot more to do yet, but I do believe that it's increased the satisfaction of the people that are in them. The problem is there are not as many of them.
Yeah.
And I know that the need keeps going up, and that is a big problem. We have actually enhanced our screening. I actually have kind of stayed with what I thought I could handle. I think the other lady talked about this really, it's really a decision that's tough to make, and that is if you screen for social determinants of health and you can't do anything for them after you find out what their needs are, I'm not sure that you've made it worse. As far as opening up wounds and what else you can't help them with, and that because what people need is hope, and that there is going to be a better tomorrow. So what I've stuck to with residents is ACEs screening and the therapy that we can provide. And I've been kind of on a kick of upgrading. We have for a rural federally qualified health center, I've got 2 sites. We've got about 9 either psychiatric nurse practitioners or therapists of some kind.
Okay.
And we're all upgrading to you've heard of EMDR for trauma therapy, eye movement desensitization reprocessing. We're actually trying to upgrade our therapy skills to be able to help people learn, actually heal from traumas that they've had either as a child or an adult, and then learn better coping skills and resilience, and maybe have a little bit better chance of working with us on some problem-solving solutions together. But that's as far as I've gone. You throw in all the other social determinants of health, that is extremely frustrating. I know that's what NAC wants us to do,
Yep.
but I'm not, I actually think we've got to load it on our practice management software, but I'm not there yet. We do have ACEs on our practice management software and use it, but I can't screen for something I can't help with. And I think that's what the other lady was referring to. What do we do when there's nowhere to go? So, and I think NAC wants us to do it to be able to show the funding, congressional funding people that, hey, look at the need here. This is what we need. And my congressmen have been to our places.
Yeah.
We've told them what we need. But there's a whole lot of other people asking for the same thing. And, between various and sundry things that have happened financially at both the federal level, and then remember, I'm in Illinois, and I think we're in first place of the worst funded state in the country right now. So we really are having a bit of a time. So that means we have a really low reimbursement rate for things like Medicaid reimbursement. It's really tough for us to add on any new services or say, hey, we're going to partner with this one and we can throw this much money in to make this happen. So that's where we're at.
Okay. I understand your point. You're concerned about frustrating the patient, but you think it's worth it, as you mentioned, to collect the data so that we can make the case, I guess, identify the need and make the case or try to develop some solutions.
Well, I've been tiptoeing that way, but I haven't done it yet. I know that we have it available. Actually, NAC had the software for free too to incorporate, and we use a package called NextGen, and I know it worked for that. But I just, I'm going to agree. I'm going to agree with you. I'm not there yet.
I wanted to add something. We also
Sure.
have NextGen, and we've been working with the vendor to, to incorporate the social determinants. And I want to get back to some studies I've done. CMS, through the Healthy People, whatever it is now, 2030s, has they've said, I think back in 2020, they said, or for that 2020, Healthy People goals and priorities was that they wanted to collect at least 2 social determinants around each patient per visit. And then they were going to do this for 10 years? And then at the end of 10 years, I guess they were going to figure out, I guess there's this trend or this pattern going on. Let's put some funding. We're not waiting for all that. That's not the way we're doing it. But we are going to collect that data, because also if you have, patients in your office and you're asking them, you pick which 2 or whatever social determinants you want to ask about that relates to services that you have or you can have resources to that you've established with other organizations. I mean, that is a way to ask them about their homelessness, for example, or where they're living, so that if they are in the street with their kids, if that pediatric visit, that provider does need to know about that. Otherwise, Johnny's asthma is not going to get a hell of a lot better. Whether you can find the end of that or not, you still need to, the provider still needs to know. And I know that really helps us with our, health outcomes that we're required to meet, for PCMH and all this business. And I just wish there were more resources, but at least then the patients will open up and they'll tell you, and maybe that will help, help them, that somebody's listening. Not that we're promising, but that at least something needs to happen here.
Okay. And Kim, how about in Pittsburgh? What are you seeing in public housing in Pittsburgh, and how are you guys working with the public housing agency or maybe some of the nonprofit housing agencies in town?
Well, there's still a lot of public housing, the traditional public housing, but they've built so much new. It's mainly the income based now. Yeah. And our public housing, they're kind of hard to work with. I'm the outreach coordinator in the Hill District section of the city, and there's a lot of public housing there. And I have my contacts that I work closely with, but trying to get them on board with a lot of things is a little difficult.
Okay.
I've had issues, with them in the past, trying to, get in there and try to, get the word out. But a lot of it's transferred over to the income based now.
Okay. And actually what you touched on is really a great point, because what we want to think about, or we've been thinking about in realizing that all these changes are taking place, and again, it varies from place to place in the country. But, if our goal is to, provide services, to the underserved and particularly residents of public housing, and the nature of that public housing is changing, some of the traditional, methods may be a little trickier and require kind of some new relationships and some new, efforts to make it work. Because, for example, one of the things that you lose sometimes as there are changes from city to city is, public housing usually has, or especially a larger or fairly large public housing agency has usually some kind of resident services manager or director or coordinator or whatever. And they focus on, basically health and wellness and a lot of these social determinants stuff, really. And where folks are going now sometimes to vouchers, and maybe they're using the voucher to say rent a private home or something. They're kind of separated from that kind of support and service. So how are we, in the health center world, going to make sure that, for one thing, when somebody leaves public housing and goes to a voucher, sometimes they need a transition because a lot of people get lost. All of a sudden they have transportation to deal with. They have additional costs to deal with. They're kind of out of their neighborhood and sometimes without maybe their family or friend support network, and it becomes a real issue. So I'm just curious, as and you mentioned the housing authority is difficult to work with in Pittsburgh, Kim. Is there anything that has worked as you've been as they've been going through some of the changes?
Not really. I've been like I said, I've been trying. I have like 2 people that I can really work close with from the housing authority.
Yeah.
But past those 2, I run into a brick wall.
Mm-hmm.
That
we've had a lot of
in
changes.
San Diego. Totally happened in San Diego for how many years? Is that they're totally uncooperative down here.
Really?
We have more cooperation from the national level.
Huh. Okay.
That's something that we need
All
to
right.
address
So,
further.
But I have to say one thing that has worked is the whole lead screening.
Okay.
Where we go in, we partner with the HUD down here, and those programs have happened in the past. And you do the lead blood content, and because these buildings are old, and and then redoing certain areas in the neighborhoods. Maybe the park used to be on top of a gas station. That kind of thing.
Thank you, Sarah. And I believe that the collaborations piece, probably we are going to address it when we discuss a little bit on the initiative that is the ambition centers, because I believe that there is a very good opportunity in some communities to collaborate with the public housing agencies and community organizations. But I do have a question for those who are experiencing new income-based housing and probably moving from traditional public housing. The question is basically if these duplexes or new buildings are located in your same service area, and if this is impacting the way, or if this is going to impact the way that you are counting public housing residents. Because just as when you report your UDS, specifically line 26, table 4, you report all patients who are seen or who receive services in the health center that is located in or immediately accessible to public housing. If you have some people who are moving from the developments to any of these new income-based locations, if you believe this is going to impact the way you are counting the patients. Kim or Kent, do you have an idea?
Yes, we have a very coordinated transportation program, and on top of that, the scattered housing is pretty much in the same service area as the traditional housing was.
Okay.
So we really haven't had much impact in our rural areas because of it.
Great.
The same with us. I mean, all the new housing is in the same area, so it hasn't really impacted them. They're still in walking distance, or they're a bus ride away.
Okay.
That's great. Thank you. And I believe that we are going to move on.
And folks, we're running kind of late, so I want to take care of a couple of quick housekeeping issues. One, how many folks will be going to P&I in March, and how many will be available for the task force meeting on the 28th of March?
I will be there, and I should be available.
Okay.
This is Zara. I'm not sure yet.
Okay.
This is Kent. I will not be there.
And Kim?
I have no idea. That's up to Len Lavender.
Okay, I understand. Well, I hope one of you will be there. That would be great. And how about CHI? That's in August, which I know is a long way off right now, but I'm just curious as to who's going to be there.
I will be
I'm
there,
not
and
sure.
I should be available. I'll be available.
Okay. Sarah?
I will possibly be there, Kent.
Okay. Zara?
Yeah, I'm not sure yet.
Okay. Kim?
Again, it's up to Len.
Check the line. Okay. All right. Okay. So jumping back just for a minute, there's a couple of things we want to touch on. First, Envision Centers, and I would like to get a little feedback from you on Envision Centers. Has anybody been contacted? Is Envision? I know there is an Envision Center in San Diego. So I'm curious, Zara, has there been any outreach or any discussion with you in San Diego or any of your other health centers in San Diego that you're aware of?
I vaguely recall the whole Vision Center thing. We have our own optometry, retinopathy. We go out to the schools, all that.
Yep.
So I'm not sure. I don't really remember the whole dialogue between that and the Envision whatever center.
Okay. But
I don't even remember what it's about, actually.
Okay. Well, basically, I'll give you a quick overview. It's a HUD program that is focused on self-sufficiency for residents. 4 pillars: economic empowerment, educational advancement, health and wellness, and character and leadership. Health and wellness, obviously, is us. And in fact, of the only 3 goals that they state under health and wellness, 2 of them refer specifically to federally qualified health centers. They're really very simple goals. One is to increase the number of adult physicals. The other is to increase the number of prenatal visits. And the third is to increase the number of preschool screenings. But the first 2, the physicals, prenatal and adult, are specifically reference FQHCs. So the notion is...
Yeah,
go ahead.
I've heard of, like whole person centered care initiatives. There's been a lot of talk, but the only one that's actually taken root here in San Diego has been and going to be coordinated through the managed care plans, is focusing on people kind of like the whole person care, but just starting with the population that have chronic disease, have been in the hospital at least once or 3 times, whatever, within the last certain 6 months, let's say, have been arrested. So they're looking mostly at starting this with the homeless population and meeting certain indicators and benchmarks.
Okay.
And I totally apologize. I heard this vision thing, and I'm like, wait a minute. Is it about the eye clinic? Yeah, but it wasn't. Anyway, thank you for explaining.
Sure. I mean, and there are only 17 cities right now that have been identified, but they said they were going to be talking to some others and kind of looking to maybe adding some on. But honestly, because of the shutdown and some changes in personnel at HUD prior to the shutdown, communication has been a little bit off. So I'm just curious as to what, if anything, people are hearing out there in the real world. So anybody hearing anything in Pittsburgh, in Illinois?
I haven't.
No.
Okay. Okay. Yeah, the site is in Chicago for Illinois. Pennsylvania, I think, has a site, but I think it's Philadelphia. And I think Texas has a site, Alan, but I'm not sure of the location, offhand. But I'm sure it's not you guys. But I'm just curious if anybody's has heard anything from anybody. And I'm going to take that as a no. All right. So next, other item, the Ideal Health Center. Have you guys been involved in? Have you heard from Jim McRae regarding the Ideal Health Center? Have you provided any feedback regarding the Ideal Health Center 2025? Does that ring any bells with anyone?
Not with me, no.
Okay.
No, not with me. No.
Okay.
No.
Okay. Well, it's something that HRSA has just begun thinking about. They did ask for some general feedback, from PCAs and HCCNs and NCAs at the PCA meeting in November. And you can see, I don't know if those of you can see the questions on the screen, but some of you can. So some of the 3 questions focused on in the discussion were, what are the key attributes of an Ideal Health Center in 2025? in terms of broad areas like workforce, financing, operations, care delivery, infrastructure, and outcomes. Then what is the role of each of the following strategic partners, the state regional PCAs, the HCCNs, and the NCAs. And again, this was a meeting for PCAs, HCCNs, and NCAs. And then how can we best work together to develop a learning health center system to support the ideal health center as you go through it. So we just want to keep you aware of it. I'm sure if you're going to the winter meeting, I have a feeling there'll be some discussion on it. Because I know Jim touched on it, like maybe very briefly in one of his, his nationwide twice-a-year call things that he does. So I would think they'll talk about it, but I would just kind of be aware of it because it's, probably be we'll call it the next big thing in terms of, what we're focusing on. And I think they're just trying to do a little visioning of what it should look like based on all the changes. And some of the changes we're talking about here today, I mean, changes, in kind of changes in housing and SDOH related things, changes in technology, changes in care delivery, changes in funding, all of the above. So I would just, keep your eye on it. And as we get more on it, we'll pass it along to you guys. But it's really just kind of getting going, and I think they'll probably mention it to you, at the winter meeting. Next thing, smoking cessation. I'm hoping people are focusing on smoking cessation. We've tried very hard to raise up the issue. Public housing residents have a very high percentage of folks who smoke, much higher than the national average. And I always say this, but I'm going to say it again. Diabetes is HUD's or HRSA's major issue right now. But about 80,000 Americans die from diabetes-related illnesses. 480,000 Americans die due to smoking-related illnesses, and there's about a 30-to-1 ratio between the number of deaths from smoking and the number of people who have smoking-related conditions. So for everybody who dies, there are 30 people who have other smoking-related health issues, and that comes to about 15 million Americans. So it's a major issue, and about a third of public housing residents are smokers, as compared to what the national average now, which is down as the latest numbers, I think down to around 14%. And so it's obviously something crucial to the people we serve. We are working right now on a Project ECHO initiative with the American Cancer Society, the Smoking Cessation Leadership Center at the University of San Francisco, and with the North American Quitline Consortium. And so we're going to be probably providing updates on it. We're trying to work with them to see how much of that experience and the information that we basically, the project involves 6 states that we're going to work with or are working with. And I think the 6 states offhand, I believe Texas is one. We've got Kentucky, Pennsylvania, New York or New York City, Florida, and California. California is definitely in there, and it's different initiatives. And one of the key things, based on a session where we worked on a bunch of issues for a couple of days 2 weeks ago, is utilization of the Quitline. And I'm curious regarding smoking cessation, just from you guys, are your folks using the Quitline? And I'm very curious as to how they're using the Quitline, and I'll tell you why in a minute.
Yeah, this is Alan. To the best of my knowledge, they're not using it.
Okay. How about you, Zara?
No, and frankly, everybody does recognize that all these diseases and things and behaviors are related. However, the issue is that there's a lot of stressors within our vulnerable populations, and it's like which one are you going to go after first?
Understand, and that's been the traditional feeling. And in fact, a lot of people feel that the behavioral health community in particular has really encouraged smoking use because they use it as an alternative or a reward.
And then you look at the whole marijuana increase, and and how that I just don't see how we can be pursuing the whole thing blaming everything on the individual and their behaviors, and you need to stop this and you need to stop that. My God, there's so much going on there in their contextual environment. It's like, really?
Well, I'm sympathetic to what you're saying, and those are some real issues. But there has been some good work done, both in California and at the Robert Wood Johnson Medical School in New Jersey around alternative treatment therapies where you get a better income both for people who have addiction issues and people who have behavioral health issues, because 40% of the cigarettes are actually smoked by people with behavioral health issues. And to go back to our diabetes thing, and I always try to throw this out there. If you smoke, you are 40% more likely to get type 2 diabetes. So if you're trying to work on that goal, one way to attack it is through the smoking thing. But I am sensitive.
I totally get it. I'm not arguing. I'm saying talking to the patients.
Yep.
Who have tremendous crime in their neighborhood.
Yep.
Have their a lot of issues going on. They don't have enough money for food. This and that. They're totally stressed. They got lots of issues. From trauma from before. And what are we going to offer them? I think it needs to be a package. I'm not saying don't talk to them about smoking.
And that's exactly right, Sarah.
Smoking is going to be the vehicle? No.
But that's what this effort is designed to kind of address. There's the as you say, there's kind of the approaching it as a separate issue, and then there's approaching it as part of a greater problem and issue. And one of the focal points of SCLC is to really deal with people who have the other stressors and or behavioral health issues. And so this is a long-term project. So it's not a kind of a quick and dirty let's get something out. It's something that's going to go on probably over the next 2 years, and to try to develop some tools that actually work for folks. So we're trying to find out how we can work, because the way Project Echo works, you can't get too many people involved with it because it becomes just difficult to manage, if you know what I mean. But we're trying to work with them to see how much we can share with folks, periodically, that'll be beneficial, without slowing down the process of trying to develop, some kind of tools for folks. So just wanted, and this is going to go on. We're going to have bi-monthly meetings with them, working on this stuff over the course of the next year. So there's a lot of stuff going on. And then we talked about Envision, and then I think we're just about out of time, guys. Does anybody have a concern or a last point or a question or something you would just want to tell everybody?
Yeah, we just, LaMaisa just had a launching of our third advocacy book. This is around human trafficking cases.
Yep.
And we had a great video that I shared with Jose, and I would really hope that, through this group, we could share that, we do have, training materials, orientation materials available.
Yep.
If anybody wants to contact us for this, and the video is really impactful. It's got the district attorney, the FBI, and the victim. So it's really cool.
And I think Jose said he put it up on the site, but we can do more and try to emphasize it, Zara, and try to put out another.
Yep. Yeah, that's exactly right.
That's a huge issue that's going on in our communities.
Yep. We can definitely try to push that. Anybody else?
We have in Illinois, or we have in Macoupin County, worked on smoking cessation to some limited success, using the quit line to both access the nicotine replacement services and the once a week counseling calls. But overall in Illinois, including our area, it was very successful for some years, and it's really started to wane, not just public housing residents, but in the entire population.
Kent, on the quit line, do you guys use the referral, the e-referral service, or a fax referral, or do you just tell the patient about it and rely on them to call?
the patient has to deal with it now. We've kind of, again, Illinois is kind of limited, financially. So they've kind of taken over the process. We used to be involved in the way you just talked about, e-faxing or emailing, but they took us out of it.
Well, let me pass along one quick thing relative to that. The numbers show, at least in California, that if you just tell the patient to call versus doing the e-referral, if you tell the patient to call, about 2% of them will call, whereas if you do the e-referral, at least there'll be at least one engagement of about a third of the patients. So you do get a better result. And the second thing is that the e-referral for the quit line is being built into some, if not all, of the EHRs right now, and so which is a benefit. It makes it just that much simpler. So I just want to throw that out there.
Okay.
All right, guys. Well, listen. Hey, thanks an awful lot for taking the time, and we will be getting back to you on some of the issues we discussed, and we will be talking again in March.
Yep, that's exactly right.
Okay, and we look forward to seeing as many as you guys who can show up at the task force meeting at P&I.
Okay.
Thank you so much.
Take care. Bye.
Take care.
Thank you very much. Thank you.